என்ன பொண்ணு?
Happy morning, ladies and gentlemen. Happy morning, ladies and gentlemen. It is my pleasure to welcome you here this morning. I hope you enjoyed your breakfast. I would like to thank you for joining us today for this special virtual seminar on respectful maternity care organized by Department of Obstetrics and Gynecological Nursing, Pondicherry Institute of Medical Sciences, Puducherry. To begin this day orderly, let us first invoke the presence of the Almighty, without whose guidance this program would have been just black and white. Now I invite our BSc Nursing final year students for the prayer song.
All the way my Savior leads me, what have I to ask beside? Can I doubt His tender mercy, who through life has been my guide? Heavenly peace, divinest comfort, here by faith in Him to dread. For I know whatever befall me, Jesus doeth all things well. For I know whatever befall me, Jesus doeth all things well. All the way my Savior leads me, all the fullness of His love. Perfect trust in me is promised, in my Father's house above. When my spirit clothed immortal, wings it fly through realms of day. This my song through endless ages, Jesus led me all the way. This my song through endless ages, Jesus led me all the way.
Thank you, students. Our memorable hearts to become immeasurable when our guests and delegates are around us. Today, as we specially organize this virtual seminar, our hearts are inspired with joy on your readiness to be with us. Today, dear guest speakers and delegates, you are so precious to us. Thus, to formally welcome the gathering, I now invite Mrs. Leena L. Raju, Assistant Professor, Department of Obstetrics and Gynecological Nursing.
Good morning to all. On behalf of Management, Pondicherry Institute of Medical Sciences, Principal College of Nursing and Faculty Department of OBG Nursing, I take privilege in welcoming you all for this webinar. With delight, I heartily welcome all our resource persons, Madam Paula, Dr. Geeta Parwanda, Professor Kavita, and Madam Preeti for joining with us. They readily accepted our request in this critical period with busy schedules. I welcome all the resource persons. I'm glad to invite all the practitioners, educators in the field of nursing who joined us for this webinar from different regions. Definitely, you will be leaving the meeting with reorganized thoughts and information from our resource persons. I extend a warm welcome to our principal, Sister Dr. Moni, and other colleagues to this webinar. Welcome you all once again.
Thank you, ma'am. It is a matter of great pleasure and honor for me to welcome our respected principal, Sister Dr. Moni, to deliver the keynote address.
Good morning to all. Dear experts, principals of various College of Nursing, delegates. Welcome all of you to today's webinar on respectful maternity care organized by Department of OBG Nursing, College of Nursing, PMS. All of us might have got a chance to witness or assist in the process of perinatal care, either as a student or a staff nurse or as a victim. First stage and second stage of labor is a crucial period. Both women and care provider is focusing on delivering of a healthy baby without any complications. Sometimes we nurses forget about the rights of women. So that occasions, we may go through different challenges. One of that is disrespect and abuse, which violate the basic principles of ethics, human rights, and basic obligations in providing care for mother. Disrespect and abuse, a concept closely related to the violence, has been documented in many different countries as a globe. This is a global problem. Occurs in low, medium, and high income countries. This is a violation of human rights. About 1/3 of the maternal death occur in Southern East Asia, and more than 90% occur in developing countries. In a 2010 landscape analysis, Hauser and Hill described 7 categories of disrespectful and abusive care during childbirth, that are physical abuse, non-consented care, non-confidential care, non-dignified care, discrimination based on specific attributes, abandonment or denial of care, and retention of facilities. And also, a 2015 systematic review updated this framework to include that physical abuse, sexual abuse, verbal abuse, stigma, and discrimination, failure to meet professional standards of care, poor rapport between women and providers, health system conditions, and constraints. So here, the traumatic childbirth experience can have many negative effects, including unfair baby bond, unwillingness to breastfeed, post-traumatic stress disorder, and poor quality of life. Disrespect and abuse experiences in the delivery room can also be a deterrent to the approaching the healthcare services. The concept of respectful maternity care has been promoted in recent years due to the importance of ethical, psychological, social, and cultural aspects of childbirth among different populations. Traumatic childbirth experience varies from country to country, and different intrapartum factors can affect the experience of traumatic childbirth. For example, fear of childbirth, failure to take analgesics, lack of support, and transferring the newborn to the neonatal intensive care unit can be factors for traumatic childbirth. What is respectful maternity care? Here, respectful maternity care is a fundamental human right that includes respecting women's beliefs, independence, emotional security, dignity, and preferences to reserve their right of having performing their cultural rituals. What is respect? So these are we all practice. We are expecting a respect in all throughout life. So especially during the process of birth, again, women also can anticipate respect from the care provider. Here, the meaning of respect include to take notice of, to regard as a worthy, to honor, to respect, esteem for a personal quality or ability. These are the different elements of respectful approach. So there are many elements. Among that, most prominent one is, first one is honor, recognition, consideration, respecting the esteem of the woman, and behave with courtesy, respecting reverence, regard, and respecting the dignity of women. So these are the different elements of and most prominent elements of respectful approach. What are the components of respectful maternity care? The components of respectful maternity care include dignified care, consented care, confidential care, non-abandonment in care, no physical abuse, no abuse related to cost, including detention, equity in process. Why does it matter? So that mainly it is needed for patient safety, service use and health outcome, and also provided safety, satisfaction, and client retention. All these things will improve or help for enrichment of work culture. Altogether, we will go for reputation, professionalism, and quality of care. So whatever we do with the women or clients, here it will be affecting, it will be help to improve the reputation of our own institution. So for the sustainment and for the development of this respectful maternity care, there. This here. Right. Sorry for disturbance. There was a problem in connection. We'll continue with it. So for considering this development of this maintenance of respectful maternity care, there's a formulation of maternity care charter. So global respectful maternity care council is formulated that is having there is a maternity care charter mainly for universal rights of mothers and newborns. It's composed of 7 articles. That is the first one, Article 1. Every woman has the right to be free from harm and respectful treatment. And Article 2, every woman has the right to get information. Article 3 is every woman has the right to privacy and confidentiality. Article 4 deals with every woman has the right to be treated with dignity and respect. Article 5, every woman has the right to equality, freedom from discrimination and equitable care. Article 6 deals with every woman has the right to health care and to highest attainable level of health. Article 7 deals with every woman has the right to liberty, autonomy, determination, and freedom from coercion. So what are the initiatives taken by the WHO? In 2014, WHO released a statement that is every woman has the right to the highest attainable state of health, including the right to dignified, respectful care during pregnancy and childbirth. I would like to also call for the mobilization of governments and programmers, researchers, advocates, and communities to support RMC. In 2016, WHO published a new guideline for improving respectful care for mothers and women in the healthcare facilities, including an increased focus on respect and preservation dignity. In addition to the eight domains of quality of care, the framework also included 6 strategies, include clinical guidelines, standards of care, effective interventions, quality measures, relevant research, and capability building. And currently, as facility-based birth and the use of skilled birth attendants continue to be increased on quality, and RMC remains critical for improving global maternal health. These are the key action points. We need to have continuation and development of this respectful maternity care. First, we need a policy, and further we need a legal action. We need to go for education, a service delivery health system, community and social system, advocacy, and research on this area. So with all these things, we can improve our current practice and can sustain respectful maternity care. So here we have experts in this field. They'll be taking further sessions. Let us see what they are sharing with us. Thank you. Let us work together.
Thank you, ma'am. With no further delay, let us start the first session of the day. To introduce the speaker, I invite the organizing secretary, Dr. Jay Shankri, Vice Principal and Head, Department of Obstetrics and Gynecological Nursing. Over to you, ma'am.
Once again, a happy morning to all. Women's experience with caregivers during pregnancy and childbirth have an impact to empower and comfort or to inflict lasting damage and emotional trauma, adding to or distracting from women's confidence and self-esteem. Either way, Her memories of childbearing experiences stay with her for a lifetime and are often shared with other women, contributing to a climate of confidence or doubt around childbearing. To deliberate on why birth matters, we have an eminent practitioner of midwifery who had a vast experience of 35 years of home birth in a well-developed country, USA, and for 15 years in a remote area in Puducherry, India, Ma'am Paula Murphy. I'm glad to introduce her to you. After her certificate in midwifery from Frontier Nursing University, Hayden, Kentucky, and Masters in Case Western Reserve University, Cleveland, Ohio, with around 30 years of experience, she had come and settled in Oroville with one motto of serving the community and empowering the women with positive experience of childbirth. Presently, she is working with Santa Institute of Integral Health Oroville as midwife and women's health practitioner the last 10 years. She is also a volunteer being officer, board of directors in Oroville Association, Oroville International USA, Foundation for World Education. She had held various faculty positions in different universities in USA, Case Western Reserve University, Frontier Nursing University, Rush University, University of Illinois, Minnesota, Wisconsin, and two. To add to her credit, she had remarkable publications in various index journals. I'm proud and privileged to introduce you, ma'am. We are honored to have you with us today. Welcome you, ma'am. Over to you.
Hello. Thank you very much for that lovely introduction. I'm very, very pleased and happy to be here with you today. I want to begin my presentation today by giving thanks to Magesh, who is sitting next to me, helping me get my PowerPoint organized. So we want to get the slides up, yeah? I'm going to continue with my giving thanks and respect to the people who trained me. I have experienced a lot of education in my life as a midwife, as a nurse, and I have appreciated very much that they have taken the time to teach, and to teach ethics, to teach a belief system of the possibility of a better world for nurses, for the world that we work in, and for the care that we give to women. The first midwifery school I attended was Frontier School of Midwifery. That school was founded in about 1938, and it was founded with the sole intention of providing maternity care for the women who lived in the remote mountain region of Appalachia in the United States. These women would be similar to the tribal women that we have here in India. They live in a world apart. They are often underserved, they are often poor, and they are often looked down upon by others, by doctors. They are not welcome to hospitals, and often the hospital is too far away, or it's the severe rainy season, or it's the winter and there's too much snow and they can't get to the hospital. And so these midwives trained and went out on horseback. They taught the families how to prepare for birth. And when it was time, someone had to come and get the midwife, and they would go by horseback to go take care of the mothers in these remote areas. And they had better outcomes, better health for mothers and babies than the doctors in New York City. So these midwives were demonstrating that safe, respectful, basic midwifery care is one of the fundamentals of safe childbirth. The next place that I had an incredible learning experience was at Case Western Reserve University, where I got my Master's of Science in Nursing. That was a wonderful experience. And again, I was privileged to be able to hear the lectures, hear the dynamic interchange of the academic nursing professors and the faculty at Case Western Reserve, which continues to be a leader in the United States in nursing education. The thesis I did really began and demonstrated my deep interest in non-separation. My thesis was that non-separation, the mother stays with the baby. We have maternal newborn non-separation as an institutional practice. One of the ways to understand that, and how I taught the nursing faculty or the nursing staff at my hospital, was to show, if you imagine a picture of a woman and then draw a line through her every time you do something to her. You take her clothes off, you put an IV in her, you put a fetal monitor on her, you ask her to do this, to do that. You have a goal, you put lines of your power, your force, your expectation of care onto that woman. And then when the baby is born, the same thing happens. The procedures and the protocols of the birthing environment interfere and separate the mother from the baby. And so I did my thesis on that at Case Western, and I got my master's degree there in 1995. Then while I had been doing home births, after I got my master's degree, I went to work in a full medical facility, a tertiary care center with maternity and neonatal intensive care. So we had some of the most complicated patients in our whole district. We were the district center for those kind of complications, but we also had the most midwives. We had more midwives than any place else in that state of Wisconsin. And even to this day, this midwifery program, I have to be very proud of it and say that last year they celebrated 45 years of the program of nurse midwives. And when it was started in 1975, during the first 2 years, the midwife did 112 births by herself on her own. She did 112 in those 2 years. Now, the midwives do half of all the births that happen in this institution, which is about 800 a year. They have a 6.4 primary cesarean section rate. Please compare that in your own mind, what you know about the cesarean section rate of India. And the cesarean section rate in the United States averages around 22%. So a service that is being provided that is offering 6.4% cesarean section rate is excellent and really demonstrating the power of midwifery care. If I could speak directly to the person who's coordinating, if you can please put up my slides. I don't seem to be able to do that on my computer. I happen to be right now on slide number 6. If you could put that up, I would appreciate it. So on slide number 6, we would be looking at the globe. We're looking at the picture of the whole of the planet Earth from outer space. We're looking at who we are as human beings on the planet Earth, and how does respectful maternity care fit into the global perspective. And I have to say that Dr. Sister Mooney laid the groundwork perfectly for everything that I want to say about the global perspective. We are at a point where we can change the paradigm of birth. Birth is a natural physiologic process, and it is meant to be comfortable. There should be no fear, no stress. Of course it's intense. Of course it's difficult. Yes, it's hard. but it doesn't have to be fearful and painful and disrespectful. Women can give birth in a natural environment. They can experience love, joy, and celebration when they welcome their baby to the world. We as midwives can provide holistic care that includes the physical, the emotional, the mental, and the spiritual. Too often, we are judged and given a star by our name by the physical things that we know how to do, how well we know how to organize the operating theater, how well we know how to keep the cupboard stocked, how fast we can do this, that, and the other intervention for a woman. Oh, she's a really good nurse. She can do all those things. I want you to say, wait a minute, where's my heart in my midwifery? How do I bring the beauty, the silence, the peace? Those are much more difficult than keeping a well-stocked cupboard. There is the natural process of childbirth, which includes a cascade of hormones, a cascade of emotional flow that allows a woman to experience the power and strength of oxytocin balanced with endorphin. Yes, you have the powerful uterine contraction stimulated by oxytocin. You also have endorphin, which allows you to feel bliss. And this is true. The more we can allow a woman to feel at peace, to feel safe, to not be in a fight or flight atmosphere of the hormones of the adrenaline and the hormones that make us fearful, we want to bring forward the love hormones. And how do we do that? As nurses, as midwives, we do that with our inner peace, with our devotion to giving safe, dignified, calm, and peaceful care. We can be like that. The woman herself might not be like that. She might be crying. She might be wanting, mom, where's my mom? I want to go home now. You know, she might be experiencing profound emotional change, but we can bring into the birth environment peace and calm, wisdom, experience, so that when a woman looks upon you as her midwife, as her nurse, you reflect back to her a woman's strength and a woman's wisdom. Now we're going to look at the core concepts, the definition of terms that we will be using. And certainly Dr. Sister Moni also brought these terms up, and I will even further emphasize them because I am hoping that our conversations today, the presentations today, make you stop and question your practice. It has certainly done that for me. I have, since being in India, since trying to understand a totally different cultural approach to childbirth, I have gone through enormous changes in my understanding of what are these basic concepts that I believe and that I can link with the global mind, the larger global perspective that comes to us through our international relationships with places like the United Nations, for example. Now, I'm the kind of person who absolutely loves to do research. I like to do research, and I love to do historical research. And I love historical research related to my profession of midwifery and to the politics. And I want you to take a look at this picture. Look at it closely. And what do you see here? Perhaps you recognize the elderly woman sitting down. She is an icon in the United States and certainly in the world and in the United Nations. That is Eleanor Roosevelt. Her husband was Franklin Delano Roosevelt, President of the United States. She was instrumental in the establishment of the Universal Declaration of Human Rights. It was adopted in 1948 at the United Nations. And it is a lot of what Sister Moni was saying. A lot of those principles were codified. They were written and they were acknowledged and signed onto by many, many nations. One of them was India. If you look at the woman standing there, you might recognize, maybe you don't recognize who she is, but you would recognize that she comes from India. Yeah. And she's in a big coat and she has her sari is over her head, but she's an Indian woman. And I want you to know this, that in this process of developing this international code of human rights, this was based upon the shock and the shame and the horror of World War II. Many, many people never wanted to see that happen again. And so the Declaration of Human Rights came out of that basic belief that humans should never experience those atrocities again. And so today, even in this year of 2021, human rights advocates believe it is possible to have a world free from slavery, torture, genocide, and war crimes. And I would add, today, we can ask for a world free from obstetrical violence. There were many women delegates from many countries who played a key role in this declaration. Hansa Mehta of India is credited with changing the phrase, "all men are born free and equal," to "all human beings are born free and equal." Hansa Mehta, we can celebrate her. We can celebrate her birthday tomorrow. She would be 124 years old. She was born on the 3rd of July, 1897 in Gujarat. And it is to her that we have to give so much thanks for the wording of that. She played that key role in changing that terminology from all men to all human beings. This becomes really, really important when we try to understand how to approach things like informed consent regarding a natural biological process. So the definition of terms, a core concept in our discussion is informed consent. With informed consent, I would also like you to include the word informed refusal. Yes, I can consent to you putting a needle in my arm and taking a blood sample, but I can also refuse. I can also say, no, nurse, no, you may not. Now, how do we deal with informed consent, informed choice? It takes time and it requires a certain system. And that's where so much of our work has to be with creating systems that promote this kind of interaction, with primarily done by nurses. In childbirth, it's done in the prenatal time. So that in a prenatal time period, you would have an opportunity to know what are the most common interventions or the most common cares that are going to be offered or given or expected, demanded, or insisted upon when you go to hospital. If you don't know what the routines are, how can you possibly make a consent when you're in labor? It's not the time. So in my experience as a midwife, I found that a very good time is at around 28 weeks. Somewhere in that time period where a mother comes and has her glucose tolerance screening test for diabetes. And at that time, we have a big bunch of time between when she drinks her glucola drink and when she has her blood drawn. There's time there. We can talk, we can educate. So let's imagine in this picture that I'm showing you here, let's take a look at the question of episiotomy. Now, in some Western countries, an episiotomy requires full informed written consent. If full informed written consent is not obtained, the person who performs the episiotomy can be charged with assault. Assault is a crime. It is a violation of the human rights of the woman if she did not agree. Now, I have never practiced in that environment. The United States does not have that law. However, we do have many, many women who request no episiotomy. So let's imagine in this picture that we're looking at, this is Marie. She's talking to her midwife about her birth plan. So she would like to have her birth with no episiotomy. And she also has some other requests. Her most kind of in a sequence, her most important ones are, she wants to go into labor naturally. She wants you to allow spontaneous onset of natural labor. Even if I go past my due date, I want you to respect that, even up to 42 weeks post due date. Now that I know will raise eyebrows in India. I have more and more women telling me the doctor wants them to deliver by 39 weeks. So we're talking about a 3-week window there where a woman could go into labor spontaneously. Another thing that many women request is that they have intermittent monitoring, that they are free to move in the room. They are not locked into a machine and tied up with a machine with the toco and the electric current that's giving her that. And so as a skillful nurse, you would learn how to perform intermittent fetal monitoring, and you promote it. And during pregnancy care, women know that it's a good thing, it's a safe option, and there are nurses at the hospital I'm going to who know how to do intermittent fetal monitoring. That you would be able to move using a birth ball, that you would have a loved companion with you, your husband or your mother or a sister or a doula, that you would have warm compresses to your perineum. And this woman, Marie, she has done her research, and she has seen that evidence has shown that if a woman receives warm compresses to the perineum, she is less likely to have lacerations, more likely to give birth over an intact perineum. The woman has the right to request this, and the more we look, take off the old glasses, put on a pair of new glasses, and see those routine episiotomies with absolutely no consent, see them for what they are. Assault, violation of a woman's integrity. Procedures done without informed consent. Then the baby delivered directly onto the maternal abdomen. Now we're in my zone of my thesis. The baby is born beautifully, clean. Newborn babies are not born dirty. We pull up the gown that the mother is wearing, whatever clothing she has, and the baby is put directly on the mother's skin, on the abdomen of the mother. The umbilical cord is not cut. A woman could choose. She could say, my decision, my birth is, don't cut the cord. I want to see the placenta and the baby connected together. I've had women ask me for that. They want to see the placenta, the umbilical cord, and the baby. They want to see that oneness of the baby. Is that against the law? Is that something we could say, yeah, I think I can do that for you? And we respect the first golden hour. We regard the golden hour as that sacred moment, those few minutes. Really, we're speaking of an hour. It could be a little bit less or a little bit more, but let's call it the sacred hour. It doesn't matter if there's blood on the sheets. It doesn't matter if the doctor is getting anxious and wants to finish up their job. As long as you have a stable baby, a stable mother, we can safely proceed with the golden hour being very peaceful and non-interfered with. No fiddling with the fundus, no pulling on the cord, no scrubbing and rubbing of a baby that's already breathing in pink. Not necessary. we learn how to do less and be more wise with our words and with our actions, and we know how to be silent, and we can initiate early breastfeeding. Now, one of the terms that we use and that is considered, I think I would say, the word or the term obstetrical violence is scary. It scares me. I mean, I think, oh my gosh, you know, think of the times where I've thought it was more important that I needed to know something, that I did an internal exam without fully addressing the mother and explaining that I was going to be doing this, or, you know, I needed to check for this or that. And I realized the more we learn about these words, about these concepts, the more we can hold them close and live up to them, the more we become an example to other nurses, and the more we become true to ourselves. In this picture that I'm looking at here, that you guys are looking at now, we have 4 people in the room. Who is the most important person? Who is everybody looking at? And if that woman, if I had a little volume, I could turn her on. And what do you think you would be hearing? This, to me, I don't know exactly what's happening. It could be that she's birthing the baby. The head is actually coming out, and she's just doing one last, you know, one last, whoa, this baby is coming, yell. It could be that. But what else do we see? We see no one is looking at the mother. We see the woman has virtually no privacy. We see she's lying on her back. You know, there seems to be all the action is in doing things to her. No one is giving her eye-to-eye contact. No one is reminding her, oh dear, this is birth. You are so close. Don't be afraid now. And as a result, women after childbirth can feel incredibly shamed. They can be told, even at that moment, where all in that previous picture where all the women were not even looking at her, they could have been speaking. They could have been saying such things as, oh, be quiet now. You weren't screaming like this when you got pregnant. Or what's wrong with you? You shouldn't be screaming. Be quiet. You're making too much noise. The doctor doesn't like it. There are many things that could be said that would be disrespectful, harmful, and mean, just plain mean. And I would hope that all of us are always trying to be a better nurse and a better midwife and a better person. Because obstetrical violence does stay with women for a lifetime. And they tell their story and what it feels like and how they dissociate from their body. I have talked to women many times after birth. I would always go and review birth within a day or two after the birth. And one woman said something I'd never heard before. And she had a very, very rapid birth, to the point where, you know, it was just barely able for us to be able to have her on the bed and to, you know, receive the baby. It was a big tornado, a tsunami of a birth. Afterwards, when I went to speak to her, I said, well, that birth was really quick. Now you'd think, okay, quick is good. No. She said, it felt like a rape. I had no idea what to say. It wasn't that it was reflecting on me. It was so much her experience. And that is a woman in a safe, clean hospital who birthed on a bed with people there to, you know, to care and talk to her. We all talked kindly. Nobody yelled at her. Nothing like that happened. But how did she interpret that powerful experience of overwhelming, out of controlled experience of birth? And then imagine if that happened and she was also being yelled at and tied down and cut open and, you know, all these other things that could have been happening. The experience of birth itself is quite profound. So what is the other side. Where is the beauty? Where is the dignity? Where is the spirituality of childbirth? When a woman is able to open to that cascade, that waterfall of oxytocin and endorphins, and she's able to give birth with dignity and respect and her spiritual center intact, she can be an incredibly loving, calm or not calm woman who is able to receive support and help from those around her. And as we look at this picture, that's what we see. I sort of imagine in this picture that the woman who's behind her and who's putting her hands on her tummy, I think of her as like the midwife and her sister, her support person. And the person above who's bringing the water, I think of that as like her mom or her sister, her loved person who is wanting to love her during childbirth and help her with the simple thing of giving water. And it's empowered. And this woman is being respected. And if we could imagine the safe care that she's receiving evidence-based, simple midwifery care that is low intervention and high touch. Low technology, high touch. Technology that it's appropriate, but the touch, the eye contact, the words that are most supportive and profound and meaningful. And things that women remember for their whole lifetime. This is absolutely true. Now, this issue of sexuality of childbirth is, I'm not sure exactly how to approach it. Here in this picture, we see a woman sitting, maybe sitting on a toilet or on the edge of the tub, and she's touching herself. Well, in general, we keep our sexuality very private. And in all cultures that I'm aware of, the sexual act and sexual relations are very, very private things. But a woman giving birth is opening and exposing the most intimate part of her body, and it's all being stimulated and triggered by increased amount of flow of fluids and mucus and amniotic fluid and blood, and her clitoris and her labia and her vagina and perineum are incredibly stretching. The rectum, the anus is opening up. She may pass some stool. And some women, when they start feeling that incredible intensity of the actual birth, they feel like their clitoris is going to split. And it's a very natural thing. I've seen many women right away put their hand there. They want to give counter pressure against that, and they end up it's an interesting maneuver because it ends up flexing the baby's head in actually a very nice way. It's going to bring the chin down to the chest and bring your smaller diameter to the crowning, which and takes some of the pressure off of the clitoris, which is where you can feel excruciating, intense sensations during childbirth. And so here we have a fully crowning baby's head. How many of you have ever seen this? This is a very well-controlled, stretching perineum with gentle birth, no episiotomy, no extraordinary pushing effort, just allowing that baby to come forward. And, during this preparation for this program, I was trying to think, because of this human rights angle, I was thinking, okay, so human rights, we have, yes, healthcare is a human right to autonomy in my body, that I have the right to respect and equality, not that I'm a woman or a man, that I'm a human being. But then I thought, what is a similar physiological process that a man goes through that is completely natural, completely physiologically driven, hormonally driven, independently managed by the human body. What does a man do that is similar to what a woman does in childbirth, for which she is required to go to a hospital, to have all these interventions, to relinquish all of her, virtually all of her independence and all of her decision-making to the institution, to the doctors, to the nurses, to the care providers? What possible situation could a man be in where he had to have a natural process regulated like that? So I thought of a couple. I thought of, well, there is the male erection and orgasm. That's a pretty sexual thing. Requires a flood of hormones, requires men certainly appreciate being able to touch their own body. They appreciate independence, autonomy. They're going to be self-directing. They're going to do it the way they want to do it. And then I thought, okay, well, we certainly don't do that in a hospital. We don't do that with a million rules about how you can and can't do it. And so I wondered if that could possibly be an analogy, but I'm not sure. So I'm going to leave that up to you to think if you can find an analogy to something a male does that is similar to what a woman does in childbirth. Because otherwise we really have to look very, very carefully at how much we're interfering with the human biology and the independence of the woman herself. Then I want you to think about the role of midwife in promoting respectful maternity care and how do we do this? And I suggest that since you all are pretty much students or you're professors and you've already understood your profession pretty well, but we're all the time learning about the history of our profession. Do you know about the history of midwives in Tamil Nadu? Do you know about the history of midwives in your own family? Learn about that profession in around the world. There's some incredible stories, so much bravery and compassion. Connect to your own inner calling to care for mothers, babies, and families. Be true to yourself. If you are not true to yourself, you can't be true to a mother. Be true to yourself. Don't be true to the people above you. Don't be true to your supervisor. Don't be true to your doctor who's taking charge of the operating theater. Be true to yourself. That is the only way you can be truthful to others and the only way that you will begin a practice and a lifelong devotion to a practice where you will run into walls, you will run into barriers, you will run into obstacles that you can't even imagine now. But you're all the time speaking for women. Your voice is not for yourself. Your voice is for the women that you take care of. And when you really know what's going on, get smart. Be the person who says, you know, we don't need to cut the umbilical cord now because the umbilical cord can continue pulsing and the baby gets a nice transfusion. And you could know the actual evidence base around that practice. And by not cutting the umbilical cord, what is the secondary effect? The mother and the baby stay together, which is another evidence-based important event in childbirth. If you, from the beginning of your practice, or from this very day when you've learned so much, you're learning so much about respectful care, if you begin saying, now I'm going to do this, I'm not just going to give up on all of this, I'm going to be true to myself and follow my inner calling, you can connect to the global birthing community. There's so much to be learned, and there's so much happening in India right now. Lots of stuff online, Birth India, Birth Village. I could go on and on. There's many of them. And be a role model for evidence-based maternity care. There are so many aspects of care that are not evidence-based, and you can challenge them. And when you challenge them, it isn't just your voice. Your voice becomes the voice of reason, the voice of evidence-based, and the voice that stands up for women's rights in childbirth based on the evidence. So I want to thank you very much for allowing me to share my thoughts with you. And I'm having time for questions, I believe. maybe. Send a question.
Ma'am, thank you very much. You had led us in a cascade of virtual experience of obstetrical violence. Variety of and the deep-rooted concern you have to bring the change in the existing practice. I hope all those who are attending this webinar, practitioners as well as educators, might have had a reorganized thoughts, try their best to change whatever is possible within their limits, inspired. And for the next few days, at least when we see a patient, when we see a pregnant mother attending a delivery, we have thoughts of your examples. It's really a spark that what I'm doing, is it ethical or is it evidence-based? Those thoughts will flow within us. Thank you. Thank you very much, ma'am.
Yes, you're welcome. Right there. Yes, thank you very much. I'm happy that people are inspired because our work as midwives and nurses is really what a blessing. Yeah. We're very fortunate to have a profession that includes our head, our mind. We can get as smart as we want. We can get PhDs and master's degrees. It includes our heart. We can be as loving and peaceful and calm and extend our friendship and support to pregnant women. And we get to use our hands. Especially as midwives, we get to use our hands in a very lovely way.
Thank you, ma'am. If you have any doubts or queries, please put up in the chat box.
I think I'm done.
We'll have the next session after a few minutes.
There's music playing in this labor room. A birth companion to comfort the pregnant woman.
किस लिए बिठाया आपको मालूम है? मत देने के लिए.
Curtains to ensure her privacy. A government hospital with a difference that is implementing respectful maternity care. Most public and private hospitals in the country, including some of the best known ones, present a stark contrast. Listen in on the experiences of mothers who recently had their deliveries at government hospitals.
सरकारी में सब कुछ फ्री हो जाता है तो हम लोग तभी जाते हैं कि हम सरकारी में जाएंगे. डॉक्टर से वो ऐसे बिहेव करते हैं बट उनकी जो लैंग्वेज वो इतनी वर्गर होती है. हाँ जी बताइए क्या करने आए हो. प्यार से बोलेंगे तभी हम बोलेंगे कि हाँ भी हमें ये प्रॉब्लम है. उसका नाम नहीं याद गायनी का. उसने बहुत बैडली ट्रीट किया था एंड शी वाज सेइंग क्या इतना मोटा शरीर है, ऊपर से खांसी है, ऊपर से थायराइड है, ऊपर से ब्लड नहीं है, 9 ग्राम ब्लड है, मैं तो नहीं तुम्हारी डिलीवरी करूँगी, यहाँ से जाओ. तो प्राइवेट में को इसलिए अच्छा लगता है क्योंकि वो हम जब भी जाओ ना वो ऐसे हमें गाइड करते हैं जैसे पता नहीं क्या चीज़ है.
मेरा हस्बैंड प्राइवेट है, वो नहीं करवा सकता है प्राइवेट भी. फिर उन्होंने सानू रजिंद्रा ਚ ਭੇਜ ਦਿਆ ਸੀਗਾ ਵੀ ਉੱਥੇ ਕਰਵਾਓ ਜਾ ਕੇ. ਕਾਫੀ ਟਾਈਮ ਲੱਗ ਗਿਆ ਸੀਗਾ, ਪੌਣੇ 2 ਘੰਟੇ ਲੱਗ ਗਏ ਸੀਗੇ. ਮੈਂ ਪੂਰੀ ਦਰਦ ਸੀਗੀ, ਮੇਰੀ ਇੰਨੀ ਹਾਲਤ ਖਰਾਬ ਸੀਗੀ. ਉਹਨੂੰ ਕਹਿੰਦੇ ਸੀਗੇ ਪਾਣੀ ਨਹੀਂ. ਮੈਂ ਆਪਣੇ ਹਸਬੈਂਡ ਨੂੰ ਕਹਿੰਦੀ ਸੀਗੀ ਮੈਨੂੰ ਇੰਨਾ ਪਾਣੀ ਦੇ ਦਿਓ, ਇੰਨਾ ਪਾਣੀ ਦੇ ਦਿਓ. ਮੈਨੂੰ ਪਤਾ ਹੈ ਸਵੇਰ ਦੇ 4 ਵਜੇ ਤੋਂ ਲੈ ਕੇ ਤੁਸੀਂ ਦੇਖੋ 2 ਵੱਜ ਗਏ.
ਫਿਰ ਐਂਬੂਲੈਂਸ ਵਾਲੇ ਕਰਦੇ ਨੇ ਵੀ ਤੁਹਾਨੂੰ ਕਿਲੋਮੀਟਰਾਂ ਦੇ ਹਿਸਾਬ ਨਾਲ ਪੈਸਾ ਲੱਗਣਾ ਆ, ਇੱਥੇ ਨੂੰ ਲੈ ਜਾਓ ਤੁਸੀਂ. ਫਿਰ ਉੱਥੇ ਜਾ ਕੇ ਰੌਲਾ ਪਾ ਲੈਂਦੇ ਸਾਨੂੰ ਇੰਨੇ ਨਹੀਂ ਇੰਨੇ ਪੈਸੇ ਦਿਓ, ਅਸੀਂ ਵੀ ਤਾਂ ਦਿਹਾੜੀ ਲੈਣੀ ਆ.
प्रॉब्लम ऐसी टॉयलेट थी जो कोई साफ सफाई भी बिल्कुल नहीं थी. जहाँ पर मतलब पानी भी ऐसे रहता था. मैं तक कोई जाती सी लेडी उसकी ब्लीडिंग भी ऐसी पड़ी है, उसको ऐसे रहता भी उछाली आती हैं सीधे.
वेटिंग हुई है ना, नर्स बोल रही है अभी नहीं देंगे. मैंने कहा क्यों क्या बात है. कह रही पैसे लेकर आओ. मैंने 200 रुपया लिया और दिया. कहती नहीं 500 रुपया लिया फिर वो बच्ची को दिया. तो असी डॉक्टर कहते जल्दी से को शीशों में रखना है, बच्ची को कमज़ोर है, मशीन में डालना है.
हमने सरकारी हॉस्पिटल डॉक्टर तो छुट्टी में थे. हम गए रात को तो जो मुझे दर्द हुआ तो वो कहते वो ले जाओ भी, यहाँ पे नहीं, डॉक्टर छुट्टी पे है. तो फिर उन्होंने कहा, फिर हम वहाँ पे गए. उन्होंने कहा भी पानी की थाली भी फट चुकी है और नाड़ू बच्चे का विचकार में है. फिर उन्होंने हमें रेफ़र कर दिया 32 में. हम 32 में गए. फिर 32 में इसकी डिलीवरी हुई.
वहाँ पे कुछ ऐसा था कि जैसे 300-400 के करीब पेशेंट्स होते थे तो एक ही डॉक्टर बैठा है. बीपी के लिए आपको मतलब लाइन लंबी इतनी इस कंडीशन में इतनी बुरी हालत हो जाती है कि खड़े रहो. मतलब जब इतने ज़्यादा पेशेंट्स आपको पता है कि गवर्नमेंट में आते हैं, ठीक है, सभी आते हैं, छोटे बड़े लोग सब आते हैं, ठीक है, एक ही बीपी ऑपरेटर से आप सबको चेक कर रहे हो, ठीक है. कोई बाहर इतना हरास हो रहा है, इतने खड़े हैं तो मतलब वो अपनी बातें गपशप में लगे हैं, चाय पी रहे हैं, इतनी रूडली बिहेव कर रहे हैं, वो मेरे को बिल्कुल अच्छा नहीं लगा.
These voices find resonance with women in different geographic locations in the country. Women define respectful care as an indicator of quality of care. They talk of availability and access, of cleanliness and hygiene. Take, for instance, denial of care caused by lack of infrastructure like beds. This room has 2 mothers and 2 babies on each bed.
प्रॉब्लम तो है मैम. देखो जैसे मैं लेटना चाह रही हूँ, मुझे लेटने की स्पेस नहीं मिल रही है बिकॉज उनका भी बेबी है, उन्होंने भी करना है, इसलिए प्रॉब्लम है. इवन कि पीछे मैं अगर बैग अपनी लगाना चाह रही हूँ वो भी नहीं लगा पा रही. तो अनकम्फर्टेबल तो दोनों ही हो रहे हैं.
Fear and distrust, leading to underutilization. While the number of women who deliver at government hospitals has registered an increase in the last 10 years, there has not been a proportionate decline in maternal and newborn deaths. The maternal mortality rate has reduced to 167 for every 1 lakh live births, but it is still over twice the target of 70 set to be achieved under the Sustainable Development Goals. Sustained efforts are necessary to bridge the gap. According to the White Ribbon Alliance, a network of maternal health advocates, there should be zero tolerance for disrespect and abuse in any kind of facility.
In order to make respectful care standardized, we need to work at multiple levels. I think the first thing that we need to do is we need to talk to providers. We need to understand how do we create an enabling environment where the providers can actually provide respectful care. I think we should not undermine this necessity. I think the second thing is we need to focus more on paying enough attention to the needs of the women. And I think the third and very important thing is how do we really include women, their families, and the communities in trying to ensure that service uptake is better, service availability is better.
The government says it is ensuring improvements in the experience of childbirth in labor rooms and operation theatres across the country. The objective is to provide respectful maternity care.
The government has recently launched Lakshya program, which is basically, focused on immediate, intrapartum care as well as immediate postpartum care. So here what we have done is that, this Lancet paper had come earlier, which showed that, if you give quality of care at birth, you can reduce 46% maternal mortality and, 40% neonatal mortality, including stillbirth. And already, 7 states we have done state orientation, and 250 facilities have been projected to where this program will be rolled out. We are taking, medical colleges, district hospital, and FRU, or first referral unit, in the first stage. We have a checklist which will be run, and then we have our parameters on which the facility will be basically evaluated. We have already allowed birth companion to the women in labor room. We have also shared standardization of labor room designs, which we have shared with the states.
Coming up after the break, a unique hospital committed to respectful maternity care.
என்ன பண்றோம்? நான் கிளாஸ் எடுக்க போறேன். வெயிட், அம்மா பார்க்க போறியா? அப்படி தள்ளியே உட்காந்து டிஸ்டர்ப் பண்ணக்கூடாது.
There's music playing in this labor room, a birth companion to comfort the pregnant woman.
किस लिए बिठाया आपको मालूम है? मत देने के लिए।
Curtains to ensure her privacy. A government hospital with a difference that is implementing respectful maternity care. Most public and private hospitals in the country, including some of the best known ones, present a stark contrast. Listen in on the experiences of mothers who recently
We'll move on to the next session. I'm happy to be the moderator for this session on initiatives of government towards respectful maternity care. I'm pleased to introduce the eminent speaker, Mrs. Kavita, Associate Professor, working currently in Mother Teresa Postgraduate and Research Institute of Health Science, Puducherry. Madam has completed her UG and PG in Tamil Nadu Dr. MGR Medical University. Ma'am is pursuing her PhD in SRM University. Also has additional qualification of DHHM, MSc Psychology and BSAM. Member in TNI, SOMI, IMA and university bodies. Participated in various international and national conferences, seminars and workshops. Attended various faculty development programs and refresher courses. Madam has published research articles in international and national journals. The floor is yours, Madam.
Is audible? I'm audible?
Audible, ma'am.
Yes. So maternal health is nothing but the health of the woman that has to be considered during the pregnancy and the labor, as well as the postpartum, that has to be treated as such a dignified way. So during the maternity period, the main causes for the MMR is the APH and the PPH infection and sepsis. That is the main causes that has to be reduced. That is the main focus is given by the safe motherhood. The safer motherhood, the initiated one thing to reduce the MMR and the IMR, and next one is the initiation of 100% institutional delivery. That is the main focus is to taken over the safe motherhood day, safe motherhood. So, but if you're seeing for the impact over the safe motherhood, there is an impact. One is there is the institution delivery is increased compared to home delivery, but there is a negative impact over the skilled birth care utilization because they don't want to come to the hospital because they have conducted worldwide study. Developed countries, underdeveloped countries, as well as developing countries, including India, because it's have the two obstacles. One is the financial barrier. The next one is they have fear about the stuff because they are not treated as a dignified way while during the care, while delivering the baby. That is the two focus given by the midwife. That is a negative impact over the safe motherhood. So the WHO taken the initiative that this had to be treated as a respectful maternity care. So what do you mean by respectful maternity care? Once the mother's coming to the midwifery care, so coming to the labor, all the women has to be treated such a manner, maintain such a dignity, and privacy has to be maintained, confidentiality has to be ensured, freedom of the choices, maybe the position as well as they should not supposed to treat any mistreatment, maybe the physical abuse or maybe the mental abuse, they should not supposed to withhold for the treatment. This should not supposed to do. That's of the recommendation given by the WHO. Before giving the recommendations, the WHO and WRA, White Ribbon Alliances and Tractions are all together taken the worldwide analysis, systematic analysis was done. The find out some of the things is there. So one is barriers. There is a financial barrier is there throughout the world. The financial barrier is the find out there is a disrespect and abuse is there. So disrespect and abuse may be happened in the hospital because the policy is not a rigid policy. It's won't have the standard procedure. Next one is infrastructure is not good. Next one is the individual, the community barrier also is there. These are the contributes to taking further disrespect and abuse. At the same time, there is a breakage over the skilled birth care utilization by the community people. That's a woman. So one is maybe the cultural birth preferences because they want to be culturally delivered in the home delivery. They don't want to come to the hospital delivery. Next one is disrespect and abuse in the childbirth. Maybe the physical abuse or the verbal abuse. They are not taken any consent during the care and no, they are not maintained the confidentiality, non-dignified care and abandonment of the care. These are the some of the things is there. Next one is financial barriers. The financial barriers, the one is the inadequate provisions of minimum obstacle care because they are not able to meet it. For example, this companionship has to be done. The companionship in the private hospital has to be done along with the companion to go for the normal delivery. They have to spend at least 40 to 50,000. That is a financial barrier. So next one is poor facility and infrastructure in the hospital, maybe the especially basic. So water facility and electricity, equipment, supplies, everything. Next one is weak road network. They won't have the proper access of facility, transportation, and lack of communication and availability of emergency transportation. This and all is lack of financial accesses. Next one is non-financial access also is there. Non-financial accesses that's fully based on the individual, that is a staff nurses who's giving the care, as well as obstetricians who's rendering the care in the labor room or delivery or the recovery room. The next one is perception of the community people. One is perceived or really negative provider attitude. Suppose seeing the discrimination, seeing the patient's dress and sex and religion and humanity, human, where they're coming from region, these are the discriminations given to the people. And poor quality of the care reported in the facility during the childbirth. Next one is a low level of competency. Those who are giving the care, staff nurses as well as obstetricians, they are not skilled enough to giving the care, or they are not able to meet out in case of the emergency or any obstacle labor. They're not able to find out the mother is going for a obstacle labor. These are the some of the financial barrier is there. These are the done by the worldwide data analysis by the Bowser and Hill 2010. So the Millennium Development Goal says that all the deliveries has to be conducted 100% skilled birth attendance. That should be there. But at the scenario, there is underutilization of skilled birth care. That was the existing scenario. That has to be taken away. How we have to taken away? For that one reason is we have to give for the respectable maternity care. What are the lacunae is there in the infrastructure as well as the disrespect and abuse that has to be taken off. So WHO has given the framework of maternal and newborn health is during 2016. That has to be revised in 2 times. 2015 that was initiated. Again, that is minimum threshold are taken off. As well as that was reframed in the 2016. That's how the structure process outcome. The structure is the health system, and the processes, the main is the quality of the healthcare. The quality of the healthcare, that's the provision of the care as well as the experience of the care. The provision of the care is includes, one is the evidence-based practice of the care should be there. And next one is there is a reference system. The standard of reference system should be there. The communication, if you want to give midwifery care, that should have the effective communications care. C is the effective communication. A is a positive attitude. That should be there. Positive attitude, or is the respect of the patients. The E is the conducive environment. That is a very important, the 4 component care. So next one is the competent and motivation human resources and essential physical resources. The outcome is the health outcomes, the utilization of healthcare facilities. That was the WHO quality care framework. So next one is for that we have to follow human and childbearing rights. The human rights is nothing but all the human being has to be possessed and enjoyed simply is has to be treated as a human being. That is given by United Nations General Assembly 1948. Some of the characteristics of human rights are that is internationally guaranteed. The next one is legally protected, all the human rights, and cannot be taken away. The human rights are equally distributed to everybody. That should be interdependent. That should be universally treated to everybody, that accepted and protect the individuals as well as the groups. That is some of the human rights. And coming with the childbearing human rights, White Ribbon Alliances 2011 is adapted some of the disrespect and what are the standards of the care we have to give and what are the childbearing rights is there. So the Bowser found out one of the disrespect is happen in the maternity ward is a physical abuse. So all the women right to have freedom from harm or ill treatment. So for example, maybe the pinching, slapping or pushing, beating. So episiotomy or giving without any anesthesia. So touching inappropriately during the examination, especially genitalia or the thighs. So these are the some of the examples of physical abuse. So the standard of the care is the staffs who are conducting the delivery avoid doing such a harmful harm And the patients has to be protected physically as well as the emotionally and prevent the sexual injury. Next one is non-consented care. All the women have the right to information and they have to get the consent over the care and whatever doing the procedure. For example, so no explanations over the medical procedure. If you're doing for that tubal ligation or the hysterectomy, you have to get the consent. Just like that for the increasing or giving the data, just like that we can't without consent, don't go for the tubal ligation, even episiotomy. So you have to give the medicine before, and we are going to do for the episiotomy and get the consent and explain the procedure before going to do it, and oxytocin before going to do it. And non-dignified care. So non-dignified care and right to privacy and confidentiality. So mother, we should not supposed to threaten. So if you are not pushing it, I'll be taking for the OT. I'll be sending for the LSS procedure. So we should not supposed to use it. Again, rude languages. We should not supposed to use in the labor room and threatening it. This one is non-dignified care. Next one is discrimination. So every woman has the right to equality and freedom from discrimination and equitable care. So mother, in case of HIV patients are admitted, again the HIV patients has to receive all kind of the care as Government of India protocol of the SOAP, standard operating procedure. So that has to be required. No need of separating or discriminating the patients. Next one is neglect. Woman has the right to health care at the highest level of the care, low cost and high level of the quality care has to be getting it. So for example, suppose we are second stage of labor, first stage of labor given the episiotomy. So after delivery, we have to suture the episiotomy. So no need of keeping the longer time. So episiotomy is the stitching the episiotomy. So taking the too long or giving the medicines or not recording it, this and all is neglecting the care. So detentions, every woman has the right to liberty and autonomy and self-determination and freedom for correction. Okay, if the baby is sick, the mother wants to be stay in the hospital along with the baby. Suppose they are not able to pay also, they have to be in the baby, with the baby. They should not supposed to withhold it. The treatment, they should not supposed to withhold it. And confidential, non-confidential care. So the woman has right to privacy and confidentiality that has to be respected, even the history collection or doing the procedure wherever the possible. The privacy has to be maintained. We should not support to discuss with any other person or disclose the materials. So for that, the government of India taken the initiative through the National Health Mission. So Health Mission, the oddly in 2017, the focus on only to reduce the MMR and IMR. So after that, the worldwide White Ribbon Club alliances, International Confederation of Midwives, everything insisted over the respected maternity care. They started with the Alexia because there is a lacunae is there in the India as well as throughout the India as well as the world. What are the lacunae? They have to find out. They given that time, and the periodic assessment has made out, and improving the labor room quality improvement initiative guidelines as prepared that has to be sent to all the government hospital in order to improve the intrapartum as well as immediate postpartum care, and along with that and the respectful maternity care. The Lakshya is insisting two things, do's and don'ts in the labor room. This is a standardized protocol has to be followed all over the Indian labor rooms, government hospital labor room. One is privacy has to be maintained once a mother's coming to the labor room, and the presence of companion during the labor. So that's according to the mother wish. Maybe the mother or the sister, elder sister, or any other aunties. So who's willing to come for the birth command, the mother birth companion will be allowed for the labor, and mother can be go for any comfortable position. So before that, we are insisting for the lithotomy position. Once the mother is coming for the labor room, once 4 centimeter of cervical dilatation or 6 centimeter cervical dilation, it's not like that. So either position, squatting position or standing position. So the mother can go for wherever they can feel comfortable. Once the mother is going for the cervical dilatation, say 8 centimeters, she has to adapt for the lithotomy position, go for the delivery. And adherence of the clinical protocol. So the mother is admitted to the labor room after 4 centimeter cervical dilatations only. Before that, we are not admitting to the labor room. So except emergency purposes, maybe the rupture of membrane is there. So we have the two types of labor room, clean labor room and the septic labor room. The clean labor room, only the mothers were admitted with the membranous plus. The membrane is absent, already membrane is ruptured, the mother will be admitted irrespective of cervical dilatation along with the observation of the protocols. And next one is use of the labor beds. So before the and all, we are using for the tables, labor table. Nowadays, that has to be modified according to the mother want a recycling bed has to be used, the comfortable bed. Next one is place the baby on the mother's abdomen. Once a baby is delivered, put the baby on the mother's abdomen. Next one is initiation of the breastfeeding within half an hour in case of the normal labor. This and all dues was insisted to maintaining the one is reducing MMR, the IMR. Next one is improving the respectable paternity care. Other don'ts is unnecessary giving for augmentation and induction, avoiding the use of verbal and physical abuse, and always insisting over the lithotomy positions during the labor room, and immediately cutting the cords. So nowadays we have to, once the pulsation stop only, we are cutting the cord. That was insisted by the Government of India protocol, the Lakshya protocol. Next one is separation of the baby from the mother. That's not a routine care. Because nowadays we're keeping the mother and baby together to increase the bonding. A very important thing, one is hope. Okay, out of pocket expenditure, nothing for the drugs or the diagnostic procedures, on giving the gift to the staffs, giving the sweets to the doctors, whatever it is, and demanding, giving money in case my female child under 200 rupees, male child 500 rupees. This and all the token is given to the government of hospital nowadays. So no money we should not supposed to give to the any expenditures like that. Maybe the drugs, diagnostic, or the gift, whatever it is. The objectives of the Lakshya is 3 objectives. One is reduce the MMR and IMR and improve the quality of the care. Next one is to increase the satisfactions among the mothers, as well as the providing the respectful maternity care. The further they have prepared for the strategies. The strategies are one is reorganizing the labor room as well as the operation theater layout. Yes. Operation theater layout and operation along with that. Next one is the caseload, whichever the caseload hospitals there. High dependency unit. According to the Ministry of Health and Family Welfare guidelines, they have to manage a complicated delivery. They are given for the SOAP, standard operating procedure, will be given to the high dependency unit hospitals. And thus, if you are coming to the ensuring the strict adherence for the clinical protocol, these are the main strategies. So the government taken the initiatives. Ministry of the Health and Responsibility taken some of the initiative, that is the equitable distribution of all services to all the individual, the timely provisions of healthcare services, provisions of quality services, and maintain the respect of the customer and customers' right to information, and maintain the confidentiality, and establishing a customer care center, conducting regular customer service. These are some of the responsibilities as a commitment are taken by the Ministry of the Health. So, so the Lakshya is given the 8 areas of the concern. One is the service provisions. What are the services provided in the medical college or district hospital, community health center, and PHC, and the patients, and how much patients will be coming to the hospital. So district hospital, community health center, PHC, as well as the medical college, because they have to segregate high dependency unit, dead caseload hospital, very less caseload hospital, and support services and clinical area. The main one is in order to reduce the infection control and quality management and outcome. These are the 8 areas will be focused. So according to that, the Lakshya team is selected. They'll be taken for the quality structured were taken out. Quality drivers will be taken on the national level as well as the state level. And the coaching team was taken out. And the quality team, the circle is taken out, especially for the labor room as well as the OT, whether the quality care will be rendered to the particular hospital as well as the district hospital, and maintaining the standard of the guidelines given by the Dakshita as well as the Lakshya. The component of the quality care improvement in the labor room, the interventions are the 4 level. The first level will be the assessment. Next one is improvement dimension. Next one is enablers, and last one is the outcome. So the outcome will be the certificate will be given to the particular hospital according to the following of the guidelines given by the Lakshya. So according to the guideline, they'll be categorized with platinum, gold, as well as silver, and simply they're given with the certificate is like that. And structural improvement was done, and process improvement was done, and the standardization they out adhere with the protocols, and the quality circles will be maintained. Maybe the infection control, whether there's a controlled IMR was reduced, MM was reduced, and the rapid improvement cycle also will be maintained off. First one is the taken of the 4 phases. First is the preparatory phase. The preparatory phase is given for the 2 months. So next one is assessment phase is extended for the next 2 months. The complete assessment of the hospital. What are the lacunae there? What are the gap analysis? And the resources are needed. After that is the improvement phase. In the improvement phase is a 12 month. It's a rapid improvement phase. In the rapid improvement phase, there's a 4 cycles are there. Cycle 1, cycle 2, cycle 3, cycle 4, 6 cycles are there. 6 rapid improvement will be taken off. The cycle 1, the generation of the real time. So generation of the real time photograph. That is the first cycle. So maybe the mandatory, all the hospitals in the labor room, mandatory monitoring of photograph and the documentation of all the procedures done in the labor room. That is a cycle 1. Cycle 2 is a birth companionship, allowing of the mother or any companion to be with the mother. That is a cycle 2. And next one is assessment of the satisfaction of the mother. Whether receiving the satisfied care by the midwives or the obstetricians or any other endurance is there. So that is a standard satisfactory scales are available. So according to the scale, they have to maintain. Next one is the third rapid improvement is assessment. The assessment, this one is a triage. Once a mother coming to the labor room, it's a triage system, whether the mother has to go for the clean labor room or septic labor room. The clean labor room, whether it's a forecervical dilatation only, the mother will be allowed to go for the labor room. Otherwise, the mother will be monitored for the first stage of labor room. If the mothers have the rupture of the membrane, the mother will be shifted to the septic labor room. That was done by the triage. Whether any complications are there, so maybe the mechanistine like any complications arise, that will be assessed, that managed. So 4th level is management of the labor as per the protocol, including active management of the 3rd stage of labor that has to be adhered by as given by Government of India protocol. That's a standard protocol, the midwives as well as the obstetrician. And if you are supposed the obstetrician using for oxytocin, the rationale has to be documented. Why they are using for oxytocin, augmentation, that has to be strictly documented. That is a cycle 4. The cycle 5 is essential and emergency care. So essentially in emergency care, Again, they have to follow with the standard operating procedures. In case of the preterm baby also, they have to adhere one protocol is KMC. Skin to skin contact must be followed, even the preterm babies also. Next, very important one is the sixth cycle, the intervention improvement phase is a biomedical waste management, the disposal. So which area the staff has to be trained, how we have to suppose to disposable and the cleaning procedure and burial procedure, everything that comes and everything is a improvement phase. So that was I discussed in the rapid movement. So coming with the interventions. So interventions, the structural improvement. The structural improvement, that are the last one. The structural infrastructure. The next one is the upgrading of infrastructure of as per norm. That is realistic according to the realistic case load of the hospital. So according to the case load, they have segregated how many staffs is needed. For example, so LDR, labor, delivery and recovery room, strictly 4 staffs should be there. That is a standard protocol. So next one is in case of deliveries taken place 100 to 200 deliveries is happening in the hospital. LDR staffs will be 4. So along with that, other staff nurses without LDR is 8 members is totally 12 staff nurses is needed. That is a human resources needed. Is along with that 4 medical officer and 1 obstetrician. The 1 obstetrician, he can able to manage any emergency care that will be arises in the hospital, and 1 anesthetist, and the anesthetist can able to manage life-saving measures that will be gone for the training also on pediatrician. This was the standard operating guidelines given by the government of India. In case of 200 to 500 bedded hospital, 200 to 500 delivery conducted in the such hospitals, again, they should have the labor room, LD or staffs 4. So along with that, without LDR staffs for 12, totally 16. So 16 staff nurses should be there in the labor room. So along with that, 1 OBG mandatory and 4 OBG is trained with all the emergency obstetrical care, and pediatrician, 4 medical officer. Housekeeping for the year is 8. So in case more than 500 deliveries happen in the hospital or medical college, so totally 16 staff nurses needed. So 16 staff nurses, including along with that 3 OBG doctors, 1 anesthetist, 4 manageable life-saving measures doctors, 1 pediatrician, 4 medical officers, and again 4 emergency care obstetricians will be given the care. So totally 8 medical officers should be there. 8 medical obstetric care obstetricians should be there. And housekeeping, 14 staffs is needed in order to maintain for the infection control. This was given by the government of India in case of the human resources. And next one is the OT. So if you are seeing for the OT, the infrastructure, there is 2 areas. There is a pre and post operative area, that is a functional pre and post operative area. And the cleaning and disinfection protocol has to be followed in the OT. And availability of anesthesia services and the monitoring area. These are the areas should be there in the OT. Next one is the zoning out of the OT. The zoning out of the OT, one is the protective area. In the protective area is water supply, water, trolley, so reception, everything is there. That is a protective area. Next one is the clearance area. This is a pre-operative, post-operative, and staff lounge that will be there. Next one is sterile area. That is a scrubbing area and OT as well as anesthetic area and the trolley setup area. Next one is disposable area. The disposable water used in the OT, the utility. So that will be disposed. Those are 4 areas will be improved over the OT also. So taken the 4 areas concerned. So all the things will be upon it. So you improve the infrastructure nowadays, even though again there's a lackness is there for the healthcare providers as well as the doctor. We are used only for reach minimum threshold of as given by the WHO. If you are seeing for the USA based Center Disease Dynamic Economic Policy, again India has shortage of 6 lakhs doctors and 2 million nurses. That was the present scenario. So the Lakshya is given the certificates, all the national aggregations, assurance, quality assurance, standards are maintaining it. If the hospital, all the government hospital or medical college maintaining 70% of score of national quality assurance standard, they'll be given with Lakshya certified facility, hospital. So once they're reaching for 90, they'll be given with the certificate of platinum. So 80, so maintain the standard, they'll be given with the gold and the silver. Again, they're given for the cash also, according to the national quality accreditation standards. So 6 lakhs, 3 lakhs, 2 lakhs in case for the 6. So the monetary benefit and encouragement for the hospitals in order to maintaining the standards. So coming with the promoting respectful maternity care. So promoting respectable maternity care, the main attainment is cognitive development of the baby. There is a fishbone scenario. One is position, comfortable position during birthing. The next one is allowing the companion. The third one is reducing the stress, because the mother, antenatal mother or mother is coming with the labor, they have the physiologically as well as psychologically stress as well as anxiety towards the labor. How they're going to treat it, because of the disrespect will be heard from the other family members. So that may be the anxiety. So these are the things will be there. That's everything has to be reduced. That was important things. So encourage the mother. That's already we have discussed. Encourage the mother to walk, move around, and change the positions. Once the mother coming to labor, any positions, whether we want to be sideline or she want to sit down, whether she without bag of membrane is not ruptured. Allow the mother to walk and avoid direct pushing. And we have to give for the perineal support. Without perineal support or urethral support, don't allow the mother to push. So again, we have to see for the complete cervical dilatations, take an head on the perineum is there for the baby or the head. Then only tell the mother to push. Just like that, don't tell the mother to pushing it. Encourage the mother. It's not a time to push. We can initiate and give for the positive adherence and reassurance to the mother when she has to push. Next one is let the mother choose the position and modern birthing furnitures. So olden days, all the government hospital will have the labor table. Nowadays, this is replaced with labor beds that will be modified. So just like that headline, head and we can able to rise it, able to mother can sit and do the delivery. So that was upon it. Next one is adequate circulation of area for the moving. So because they have to be maintained the distance, at least 6 feet distance should be there for the each car, because in this pathway we can able to freely move around by the staff nurses by the obstetrician. And the orientation of the care provided by the regarding the birthing positions, when she has to push, when she has to put the lithotomy position, that has to be explained to the mother. Again, so drinking water facility, washings for the hands facility, that is also separately should be there for in the labor room. So if everything is there, so bonding can be enhanced. So next one is the companion. So companion, if you are allowing the mother, who's a companion will be there. So we have to teach the companion when she has to encourage the mother to push. So yeah, companion வந்துட்டு the 4-6 centimeter முக்குமான்னு சொல்லிட்டு இருப்பாங்க. So we should not supposed to say the companion, when she has to push it. Suppose any physical care, maybe mother need for the water, she can able to help the mother, giving the water, giving the fluids. We are not putting for the nil per oral. So Government of India insisting no nil per oral, mother can drink and fluids and the water and fluid diet, that way can be encouraged. So that can be done by the companion, and the mother need for the sacral massage, abdominal massage, that will be rendered by the companion, because the before and all nobody's allowed, the midwife will be giving for the sacral massage, and she has to shout to push it also. So nowadays any companion is there, that is a positive assurance, she can able to go with the mother, she can control by the mother. ஏன்னா நாங்க ஒரு எக்ஸாம்பிள்ஸ் பார்த்துருக்கோம், மாமியார் வந்து இருந்தாங்கன்னா போதும், என் முக்குன்னு சொல்லும் போது மருமக ஆட்டோமேட்டிக்கா ஸ்டார்ட் டு புஷ் இட். இப்போ கத்தாத ப்ரே பண்ணு அப்படின்னா சொல்லுவாங்க, சொல்லும் போது they start, they'll be doing that. Next one is assisting the mother for the personal needs and helping in for the initiation of the breastfeeding. The companion will be taking off once the baby is delivered. We can give the baby to the companion. We can able to avoid the theft of the baby. So they'll be taken by, we can able to assure it. This is a female baby, male baby. Sex of the baby also we can able to show to them. They can able to allow it. This was the baby, female baby or male baby. This everything can be done by the companion. Okay, next one is the companion may be helping you for the shifting the mother to the recovery room as well as the postnatal ward. So the mother will have a lot of the things along with the baby. The companion can hold the baby and the mother can be shifted to the postnatal ward. So these are the some of the benefits over the companionship if you are allowing the companion to the labor room. All the basic need will be made by the companion. Next one is avoiding the stress and anxiety. And we have to insist the mother during the antenatal period itself. What are the warning signs when she has to come to the hospital? What are the warning signs of the delivery? This premonitory signs of the delivery, everything we have to insist during the antenatal period. So timely arrival is there. We can able to avoid the emergency stress. Suppose mother is coming with the bag of membrane is ruptured, maybe the full cervical dilatation, we have to go hurry enough to conduct the delivery. So mechanist and like we have to hurry enough to conduct the delivery. So we have to insist the mother during antenatal period, she has to come to the hospital. And the positive interaction with the care provider, that's very important. So whoever is in the labor room, midwives as well as obstetricians, we have to give communications very important. That's what I told you. So respectable maternity care is needed. Care, the effective communication as a positive attitude, and respectably treated the mother and conducive environment. The four things is phenomenal for the mother to receive it. And assurance has to be given to them, and avoiding the stress and triggering terms. Don't use it when abusive words. So don't be so rigid words or maybe harming the words emotionally. That kind of words should be avoided. And avoid frequent vaginal examination. Again, WHO says that once a mother is admitted without mother's consent, we should not supposed to do for the PV examination during the antenatal period itself. Once a mother is entered to the labor, the triage only, we have to find out PV examination, which is a cervical, what is the condition of the cervix, whether the descent of the fetal lead is there. For that only we have to do for the triage, do for the PV examination. After that, every 4 hours only we have to do for the PV examination. That is a standard protocol. So next one is this everything, if you are doing it, there is increasing the bonding between the mother and the baby. So the increase in the bonding between mother and the baby, we are not separating the baby and the mother. So we are not separately using for the radiant warmer. Unnecessary care, referring the baby to the newborn unit or sick neonatal unit, and delaying the clamping, because that is the initiation of blood flow. 5 ml of blood flow will be initiated to the baby. That may preventing for the anemia, newborn anemia. We can able to prevent it in case we are going for the delayed clamping. So we have to wait for the pulsation to stop. And early initiation of the breastfeeding. So breastfeeding will be started once the mother is delivered for the normal delivery. Within half an hour, breastfeeding has to be started. In case of the LSUS, 1 hour to 1.5 hour breastfeeding has to be initiated. Shifting the mother and baby together in case for the sick neonatal unit as well as the new postnatal ward. Next one is everything is we are doing it, there is a natural progression of the labor. So no need of the mothers going for the instrumentation or augmentation of the labor. So no need augmentation, no more the instrumentation. The mother can go for the safe mother check. Mother will be used and monitored with the safe mother checklist and use of the partograph, because if you are using of the partograph, we can be able to understand whether it's going for the normal labor or any obstructed labor. In case obstructed labor, the mother can be managed with the emergency care. So we can be able to avoid unnecessary C-section that can be able to done. So next one is very important things, the conducive environment. The conducive environment, the one is we have to follow the LDR concept, labor, delivery, and recovery concept. So once a mother should be there in the labor room is a 4 centimeter of cervical dilatations. Delivery has to be conducted with the privacy and confidentiality and along with the companion. In the recovery, we have to observe and observe the uterus. Uterus is contracted and the bleeding is controlled, whether some mother is past the urine, baby is initiate the breastfeeding. So everything we have to observe first 1 hour, then only we have to shift the mother and baby to the postnatal ward. So in the labor room, avoid using of the bright lights, because many studies says that bright light may be increasing the anxiety, giving the high pain to the mothers. So next one is avoid noise. Both the things are irritating to the mothers, and maintain the hygiene and cleanliness of the ward. Once the delivery is over, the delivery bed and the labor cot has to be thoroughly washed and carbolized. Carbilize that. And next one is the labor room should be the soothing colors, maybe the pink color or mild blue or green, is like that. And the privacy has to be maintained. So each mother has to be privacy maintained with the curtains or the screen, and a separate room has to be kept for the mother to go for the normal delivery. So this has to be maintained. The mother can be treated with the respectful way. There is the promotion of cognitive development of the baby, because the main thing is the stress and anxiety is reduced. So automatically the increasing the bonding between the mother and baby, they're moving towards a cognitive development of the babies. So these are the main initiatives taken by the Government of India. Other initiatives of Government of India Health and Family Welfare. Pradhana Mantri Shakti Mativa Abhiyam, PMSMA. So this program is so mainly for comprehensive and quality care to the mother. So the quality care is the free of cost. So all the women can receive the quality care once a mother is going for the second trimester and the third trimester of the pregnancy, every month, the 9th of every month. So 7 month. So the one medical team will be going there, along with the expert, they'll be giving the care. There's a separate app is available. So next one is Janani Suraksha Yojana. So Janani Suraksha Yojana is giving for the cash assistance to the woman. So 600 rupees for the rural, 400 rupees for the urban. That was a cash assistant that be conducted in the institution delivery. Coming for the skilled birth, done by the skilled birth attendant, they'll be received by the cash. Next one is Janani Sishu Suraksha Karikramam, that in case of the sick neonate is there, the free transport availability will be given to the mother till the 1 year of the baby say they come to the hospital and treat the baby and go ahead. So next very important one is midwifery service initiative. So in order to improve the competency of the midwifery care, 18 months training of midwifery only for because we improve the standard of ICM competency level. So that's what initiative is going on. The training is available in Hyderabad. The Government of India also is a formulated syllabus. They can start with 18 months course of the training of the midwifery after completing of the GNM or BSc nursing. they can take over the courses. Separately, the staffs will be called as midwives, competent midwives. Next one is the first referral unit. The first referral unit, again, this how the referral services, they provide the comprehensive emergency obstetric care and newborn services along with the blood transfusion services available in the first referral unit. MCH wing. So all the MCH wing is available in case of medical college, districts hospital, districts women hospital. In case wherever high case load facilities is there, they'll be started with the MCH wings. The next one is obstetric high dependency unit and obstetrics intensive care unit also will be started in the medical college. Who and all has been treated with the obstetric complications will be admitted for the intensive care unit. Next program is the Dakshita. So Dakshita is 3 days training program for the doctors as well as nurses in order to improve the quality intrapartum care as well as the postpartum care. And this will be training given for all the states as well as union territory. This only for the 3 days training program. The next one is a skill lab. The skill lab is initiated by the Government of India that is available in Delhi, the Trained Nurses Association of India Elders Home in the campus. So mainly for healthcare provider, they can go and stay there and take the skill for the 1 week training program. So they'll be given for the national trainers. After that, they have to start with the training in the states. So here is hands-on training will be given, all the essential care. Labor room conduction, how we have to set up the labor room. All the trainings will be given in the Daksh. So next one is training of the MBBS doctors in emergency care skills and mother and child tracking system. Anemia Bharat ANM, that will be a comprehensive holistic management of anemia across the life stages of the female. And the skilled birth attendant, again improving the quality care during the delivery and the childbirth. And next one is the maternal death surveillance and response. Here is taking the maternal death reviews. What's the reason? Why is the maternal death is happened? So they're finding out the reason. According to that, the corrective actions will be taken off over the reducing the maternal death. So what are the responsibilities of the midwives? They're given by the standard operating procedure Government of India and White Ribbon Alliances and International Conference of Midwives. So we have to follow the profession ethics. So who are the doctors as well as the midwives who is taking care of the mother. So highly we have to follow the ethics. So doctors for the FICO Ethics Code of Ethics 36 there, International Council for the Nurses ICN Code of Ethics 34, International Conference of Midwives ICM Code of Ethics 35. So everything is says that ICN nursing ethics, all the principles says that only the 4th principle: beneficence, non-maleficence, autonomy, and justice. This will be linked with your respectable maternity care. So coming with the conclusion. So we have to follow the ethics and the standard operating procedures. We have to follow the guidelines, and mothers has to be treated with the dignified and respectable way in order to maintain the cognitive development of the baby. So some of the points we have to carry over. Again, this is given by the Government of India. Please remember what is respectful maternity care. Don't forget it. Privacy has to be maintained once a mother is coming to the labor room. Avoid harmful practices. Provide complete information to the mother. Get the consent. What are the procedures you are doing to the mother? Allow mother to choose the choices of the positions in the birth table. Avoid the verbal use, and companion should be allowed, and continuous support, reassurance has to be given to the mother. Confidential has to be maintained. Allow the mother drink or food during the labor. Allow the mother to move in the labor room. Avoid discrimination, and keep the mother and the baby together 24 hours a day, and prevention of institutional violences, and avoidance of the drugs and skin to skin contact, and initiation of the breastfeeding, Everything's very important. So we have to go for the evidence-based care in order to secure or maximize the quality care improvement we have to give to the mother. We have to go ahead with the evidence-based care. Any doubt? Discussion? Any queries? I think I have justified my topic.
Ma'am, we didn't receive any questions in the chat box, ma'am.
Okay.
Dear delegates, if you have any queries, you please post it in the chat box. Thank you, ma'am, for reiterating us with the universal rights of childbearing women and children, government initiatives, Lakshya, to reduce infant mortality rate, maternal mortality rate, and respect for the mother, updated and provided in-depth information about Lakshya objectives, strategies, team members, QoC improvement in labor room, phases and its intervention, and how to promote respectful maternity care through companionship. Madam also highlighted the other initiatives by Government of India and also responsibilities of midwives. Thank you very much, Madam.
So I am including us one video.
Okay, ma'am.
I'm sharing one video. This Lakshya is initiating how we have to organize the labor room.
Okay, ma'am.
Organizing labor room. Learning objective. To organize labor room in a systematic and planned way with all essential equipment and drugs in a functional state. In order to manage all the pregnant women coming for delivery, there is a need for maintaining dignity, privacy, and quality service delivery.
Ma'am, video is not visible, ma'am. Only audio we are able to hear.
Okay. I'll get it. I'll do it.
Every labor room should be organized as depicted in the visual.
Now it's visible? Now it's visible?
Yes, ma'am. Yes, ma'am.
Okay.
Activity of the staff rendering services. In order to manage all the pregnant women coming for delivery, there is a need for maintaining dignity, privacy, and quality service delivery. Every labor room should be organized as depicted in the visual, which helps in better coordinated activity of the staff rendering services. Entry should be restricted only to labor room staff.
Ma'am, can you increase the volume, ma'am?
Okay. Or a space for changing slippers,
Now
caps,
okay?
masks, etc.
Little more, ma'am.
It should be well illuminated.
Okay.
Yes, ma'am. Thank you, ma'am.
Windows should have frosted glasses and curtains. It should have provision of 24 hours running water. Hand washing area should have soap and running water. Long handle tap, which can be closed with elbow. It should have an attached functional and clean toilet. General equipment and accessories for labor room. A functional wall clock with seconds hand. Wall-mounted thermometer. Delivery trolley with multiple shelves. Bag and mask for adult resuscitation. Pulse oximeter. Refrigerator. During winters, the temperature of the labor room should be warm, and in summers, normal room temperature should be maintained to prevent hypothermia to the newborn. The labor room should have newborn care corner and service area for routine paperwork like autograph, etc. required to be filled in during labor. Labor room should have the following 7 trays. Delivery tray. Episiotomy tray. Baby tray. Medicine tray. Emergency drug tray. Injection oxytocin 10 international units should be preloaded and kept ready for use within 1 minute of childbirth. PPIUCD tray. MVA or EVA tray. Every labor room should have a functional newborn care corner, NBCC, which has a functional neonatal bag and a mask of appropriate size and a radiant warmer, which should be switched on at least 30 minutes before delivery. Two clean sterile towels to be kept for pre-warm. Functional baby weighing machine. The service area helps in smooth running of the facility round the clock. Pantograph. Bed head tickets or case sheets. Labor register. Refer in or refer out registers. Handing and taking over register are available. Labor table, 1 or 2, with footstep to climb. Adequate light is essential. Can be fixed lamp or angled lamp. Mattress with clean draw sheet and Kelly's pad or V-tray is in place with a yellow bin kept under it. Kelly's pad and measuring mug should be decontaminated after use by routine method. Drums containing sterilized items like gloves, linen, instruments, cotton swabs, and gauge pieces. When you open the autoclave drum, confirm that the color of the strip inside the drum and on the wrapped sets has changed. Remove the strip and place it in the register. If there is no color change, the items have not been properly sterilized and the drum needs to be sent for autoclaving again. Each delivery tray should have pre-autoclaved and wrapped instruments in enough numbers so that one set is available for each delivery. Arranging newborn care corner. Ensure the radiant warmer is plugged in, is functional, and switched on at least half an hour before the anticipated time of delivery. Each warmer should have oxygen cylinder at the bottom and outlet catheter connected to the functional and pre-clean neonatal bag. Oxygen cylinder is filled with key tied on it. The oxygen flow is checked underwater in a bowl before inserting the tube. A separate oxygen cylinder with flow meter or alternate source along with all necessary accessories should be available. A pre-tested, clean and functional newborn resuscitation bag and mask of appropriate size is kept ready on the shelf just below the radiant warmer. Pediatric suction machine with disposable suction catheter number 10 and 12. Suction apparatus for the newborn should be kept ready. DVs should be available in the tray. Sterilization of the labor room. Learning objective. By the end of this video, the participants will be able to understand how to keep a labor room clean and sterilized. The process of cleaning and sterilization of labor room. Cleaning and disinfection of labor room should be daily at the beginning of the day and wet mopping every 3 hours after wearing utility gloves. The labor table is to be cleaned with phenol or bleaching solution after every delivery. Cleaning of labor room. Clean the floor and sinks with detergent, that is soap water, and keep the floor dry. Clean tabletops and other surfaces like light shades, almirahs, lockers, trolley, etc. with low-level disinfectant phenol, that is carbolic acid 2%. In case of spillage of blood, body fluids on floor, Wet the area with chlorine solution for 10 minutes. Absorb with mop. And decontaminate the mop in the chlorine solution. Mop the floor again. Discard placenta in yellow bins. Decontaminate the gloves in chlorine solution. Do not throw them on the floor. Do not throw the soiled linen on the floor. Disinfect with bleaching solution followed by washing and autoclaving. Mop the floor every 3 hours with disinfectant solution. General measures. Unnecessary entries to the labor room must be restricted. Labor room doctors and paramedics should wear a mask all the time. Proper clothing of labor room personnel necessary, including cap, mask, shoes or slippers, and gown at the time of delivery. Individual autoclaved instruments set should be provided for each delivery. Random swab sampling to be taken from surfaces and disinfected articles monthly. Microbiological samples should be taken randomly at 1 month interval by settled plate method. A chart depicting cleaning of labor room with time along with signature of the supervisor or cleaner should be displayed in every labor room. Key points. Individual autoclaved instrument set should be provided for each delivery. Delivery tray, episiotomy tray, baby tray, medicine tray, and emergency drug tray, PPIUCD tray, and MVA or EVA tray should be kept ready all the time. Labor room should have a newborn care corner with radiant warmer and the equipment for resuscitation of newborn baby. Autograph, bedhead tickets, labor room register, refer in, refer out registers, handing over, taking over register should be available.
சாமிட்டு எடுத்து வச்சிரு அந்த பூ எடுத்து சாமிட்டு வச்சிரு நல்ல பக்தியும் மயத்தோட ஏதோ ஒரு போடு அம்மனுக்கு இது வச்சு
Capacity of the participants to process the used items and instruments for decontamination, cleaning, sterilizations, and storage. This video will also show the different methods or procedures of sterilization. Wear utility gloves and plastic apron. Take 1 liter water in a plastic bucket. Take 20 to 30 milliliters of water from 1 liter measured water. Take 3 level teaspoon of bleaching powder. Stir well and make a thick and smooth solution in a plastic mug using water from the bucket. Mix this paste in the remaining water in the bucket to make the liquid bleach. Wherever hypochlorite solution containing about 5% by weight of sodium hypochlorite is available, use 1 part of hypochlorite solution in 9 parts of water to prepare 0.5% chlorine solution. Take a can of hypochlorite solution. Pour the hypochlorite solution in a plastic mug. Then, pour that hypochlorite solution in a plastic bucket and add 9 mugs of water. Take care to maintain the same ratio for larger volumes. Always make fresh chlorine solution in each shift. The container with chlorine solution should be preferably kept covered. A delivery has just taken place in the labor room. Now, after the mother and neonate have been rendered the desired services and they have been taken care of, then immediately we need to decontaminate and clean the equipment so that sterilized equipment are available for the next procedure. Now, we will show processing of instruments. Labor room cleaning staff puts the used instruments in the freshly prepared 0.5% chlorine solution. Then, she removes the gloves and puts them in the same chlorine solution. Keeps them for 10 minutes. The cleaning staff picks up the soaked instruments from the chlorine solution tub and puts them in another container filled with water. This process is called decontamination, which makes the used items safe for further processing. Cleaning. She scrubs the instrument using a brush and a detergent. Scrub the instruments in a container filled with water for avoiding splashing. Rinses them thoroughly in another bucket of fresh water to remove all detergent and then air dry. Detergent is important for effective cleaning because water alone will not remove protein, oils, and grease. Do not use hand soap for cleaning instruments and other items, as fatty acids in soap will react with the minerals of hard water, leaving behind a residue that is difficult to remove. Detergents also remove blood, meconium, and other body fluids. All the linen will be sent to laundry after decontamination. Equipment, surgical gown, and drapes are to be sterilized. Sterilization ensures that items are free of all microorganisms, that is, bacteria, viruses, fungi, and parasites, including endospores. Sterilization kills all microorganisms and is therefore recommended for items such as surgical instruments that come in contact with the blood or tissues under the skin. There are 3 methods of sterilization. Steam sterilization by autoclave, dry heat sterilization, that is electric oven, chemical, that is cold sterilization. When autoclave is not available, high-level disinfection, that is HLD, is the only acceptable alternative. Here, in this video, we will explain autoclaving and chemical sterilization. Parts of autoclave. Geared stream gauge, excess pressure relief valve, top handle, control valve, air exhaust tube, process for keeping wrapped and unwrapped items inside the autoclave, Surgical equipments and drapes are to be put into the adequate size tray. Keep the indicator strip and wrap it. Seal it with adhesive tape after putting date and signature. For the dressings, bags, cotton swabs, and other loose instruments, etc., are to be kept in a labeled surgical drum, having holes in the side, and close the lid. Put indicator strip over the drum. Place the items in autoclave loosely. Then close the lid and put the autoclave on the stove, or use the electric autoclave. This allows adequate permeation of steam inside the autoclave. Note the timing when the steam emits from the pressure valve. Keep the wrapped items for 30 minutes and unwrapped items for 20 minutes at 15 pounds per square inch at 121 degrees centigrade, that is 106 kilopascal. Allow autoclave to cool for 30 minutes before opening. Chemical sterilization. An alternative to high-pressure steam or dry heat sterilization is chemical sterilization, often called cold sterilization. If objects need to be sterilized, but high-pressure steam or dry heat sterilization would damage them, then they can be chemically sterilized. For high-level disinfection, the instruments are soaked for 20 minutes. While for sterilization, prolonged exposure for a minimum of 10 hours is needed. Remove the equipment with a sterile chittle forceps and rinse with sterile water. HLD eliminates bacteria, viruses, fungi, and parasites, but does not kill all endospores, which cause diseases, for example, those causing tetanus and gas gangrene. Boiling for 20 minutes is another method for HLD. Keep instruments in the boiling water for 20 minutes after the water starts boiling. Please ensure instruments should be completely immersed in water. Lid of boiler should remain closed throughout these 20 minutes. Do not remove or add instruments or water during this period. Storage. Sterilized items should be properly stored immediately after processing so that they do not become contaminated. Covered sterile instruments should be used within 7 days of sterilization. Once the drum is opened, the instruments must be used within 24 hours. Infection prevention. Decontamination. Soak in 0.5% chlorine solution for 10 minutes. Thoroughly wash and rinse. Wear gloves and other protective barriers like glasses, visors, or goggles. Preferred methods. Acceptable methods. Preferred methods. Sterilization. Chemical. Soak for 10 to 24 hours. Autoclave. 106 kilopascal pressure. That is 15 pounds per square inch. 121 degrees centigrade, that is 250 degrees Fahrenheit, 20 minutes for 30 minutes for rat. Dry heat, 170 degrees for 60 minutes. Acceptable methods, high-level disinfection, that is HLD, boil or steam, lid on for 20 minutes. Chemical, soak for 20 minutes. After cooling, use immediately or store. Key points. Prepare 0.5% chlorine solution every day in a plastic bucket with lid for decontaminating items used in patient care. Keep the items that cannot be autoclaved, like scissors. MVA kit in a tray containing 2% glutaraldehyde solution for 20 minutes for high-level disinfection and for 10 hours for chemical sterilization. Use properly autoclaved instruments and gauze, cotton, etc. for every case.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
If there are no queries, let us break for the lunch and we'll resume next session at 2 p.m. Thank you.
Okay, thank you once again for the organizers inviting me as the speaker, and thank you participants for the patient listening. Thank you one and all.
Thank you very much, ma'am.